It is a pleasure to be with you today. Unfortunately, I'm not with you. I'm in New York, and this wonderful meeting is in Chile. I wish I could be with you, but because of COVID-19, of course, we aren't traveling. But this presentation, I hope, will interest you, and there'll be time to ask questions about it. What I thought I would do is to discuss with you vitamin D as it relates to general skeletal health, non-skeletal health, and specifically how vitamin D may be related to the pandemic of COVID-19. So let us start at a time many years ago, in fact, in the late 1800s, when vitamin D deficiency became recognized during the Industrial Revolution. This is a picture of a young boy in Europe in the late 1880s. And you can see he has the typical appearance of rickets, namely growth retardation. He has bowing of his legs. This was a very common appearance in Europe in the late 1800s. I show you a picture on the right of someone who also has rickets, but this wasn't in the late 1800s. This was in the late 1900s in the United States. And in fact, in a recent survey just 3 years ago in the Middle East, it was shown that 15% of respondents of this survey reported that they knew of a child who had rickets. Now, the thought about rickets obviously gravitates to the sun because there are many parts of the world where sun is plentiful and provides the wavelength of energy that is required for conversion in the skin of 7-dihydrocholesterol to pre-vitamin D. And you can see in this slide in the northern and equivalent southern hemispheres, there's vitamin D for about 6 months of the year. In the middle latitudes of the world, vitamin D is available through the sun for about 11 months of the year. But what about South America? There are data here looking at levels of 25-hydroxyvitamin D as a function of latitude in South America. And there is clearly a relationship. As the latitude moves from the equator, or 0, to 40 to 60 degrees, you can see that the level of 25-hydroxyvitamin D will fall. And that is shown even more clearly here in a recent experience from Brazil, where looking at the northeast of Brazil to the southeast, you can see as the latitude increases, the 25-hydroxyvitamin D also falls. And I believe there are new similar data from Chile. Now, having said that the sun is a major source of vitamin D, it's turning out that it isn't, because there is seasonal variability of where the sun is in relationship to the angle that provides the energy that we need. As I noted, it is latitude dependent. There are concerns about skin cancer, melanoma, and skin health that limits our exposure to vitamin D. There are some parts of the world where cultural behavior limits exposure of the skin. There may also be genetic issues with regard to vitamin D resistance. Environmental pollution is a major problem that may be a factor in limiting the availability of vitamin D through the sun. And official dermatology recommendations are generally to avoid sun exposure. So I think we can basically say that the sun is no longer a major source of vitamin D throughout the world. If we do not get our vitamin D from sunlight, well, maybe we can get our vitamin D from food. But here again, there's a problem. This work comes from the United States, looking at men and women at many ages. And you can see that it doesn't matter, male or female or young or old, no one is getting sufficient vitamin D through foods that are typically rich in vitamin D. So we don't have the sunlight as a source. We don't have food as a source. And therefore, maybe we're all deficient in vitamin D. And in fact, this point has been demonstrated by Professor Lips several years ago, in which he did a convenient sampling of postmenopausal women with osteoporosis in the latitudes that you can see, and looking at the threshold of 30 nanograms per ml, 64% of individuals had levels below that. Now, what about Chile specifically? This is a recent paper that looked at individuals in Santiago, both men and women, healthy individuals. And you can see that the average level of 25-hydroxyvitamin D in Chile for women was only 23 nanograms per ml, and in men only 20 nanograms per ml. These are levels that are borderline, and in fact, levels under 20 nanograms per ml or 50 nanomoles per liter, the figures are very impressive, with 36% of the population deficient under the age of 40, and almost 50% of the population deficient over the age of 60. And looking at another country, I take for an example, a little tiny country in Eurasia, Armenia, you can see that a study that we have just completed, 54% of 1,200 women sampled throughout the country had 25-hydroxy levels that were under 20 nanograms per ml. And in fact, 20% of that population was frankly deficient with levels under 12 nanograms per ml. So, it almost doesn't matter where you look, in Chile, Armenia, United States, Europe, the world seems to be deficient in vitamin D. More recently, Roger Bouillon has shown that in Europe, 10% of the population had severely low levels of vitamin D. And Paul Lips has again shown that upwards of 50% of people in the Middle East and Northern China have really low levels of vitamin D. If you take 20 nanograms per ml or 50 nanomoles per liter as a threshold, Professor Bouillon has shown that 1/3 of the world's population would be vitamin D deficient. I have been giving various numbers, and admittedly, it is controversial as to what is normal. I think most people agree that levels under 12 nanograms per ml or 30 nanomoles per liter are clearly low and may well be associated with rickets. The various international bodies have suggested that 20 nanograms per ml will be sufficient to ensure normal mineral metabolism. That is, it won't eventuate into clinical phenotypes such as rickets. But on the other hand, recommendations for individuals with metabolic bone disease or in special situations, many organizations, and this includes some countries in South America, are suggesting that levels be over 30 nanograms per ml or 75 nanomoles per liter. Recommendations to reach these threshold values from the Institute of Medicine suggest that intake of vitamin D in individuals under the age of 70 be at least 600 units per day, and those over the age of 70 be taking in about 800 international units per day. This is a relatively safe vitamin, and levels up to 4,000 units per day have not been shown to be associated with side effects. I have spoken about vitamin D as a skeletal factor, but it's important to remember that we are talking about a nutritional agent that is involved in many other systems, not only the bones. And this slide illustrates some situations in which vitamin D has been implicated in addition to skeletal homeostasis. It's been considered to be important for brain development, for the cardiovascular system. Other hormones, hormones such as FGF23, we know there's an interaction with FGF23 and parathyroid hormone, maybe even insulin, muscle strength and falls, skin, even cancer. And very importantly, as we move to a discussion of COVID-19, vitamin D may be very important in giving competence to innate and acquired immunity. Several issues have been looked at both cross-sectionally and in prospective studies, looking at the potential effect of vitamin D on fall protection, diabetes, cancer protection, cardiovascular health, and this has been followed by recent randomized clinical trials and, of course, COVID-19. In terms of posture and balance, this study showed that using calcium and vitamin D was associated with a beneficial effect on balance. Vitamin D has been implicated in diabetes mellitus, and this study suggested that levels under 30 nanograms per ml or 75 nanomoles per liter was associated with an increased odds ratio of developing diabetes mellitus. In fact, vitamin D deficiency in this study was considered to be one of the more important risk factors for the onset of type 2 diabetes mellitus. Vitamin D has been implicated in breast cancer, and this meta-analysis suggested that vitamin D had a protective effect of significance in the development of breast cancer. Even the cardiovascular system has been implicated, and this study looked at a threshold value of 15 nanograms per ml, and in the red line you can see those individuals who had 25-hydroxy vitamin D levels greater than 15 nanograms per ml were relatively protected against the cumulative probability of developing cardiovascular disease. So these observational trials have suggested that vitamin D insufficiency or deficiency may be associated with falls, diabetes, cancer, and cardiovascular disease. What about prospective trials and the evidence that vitamin D might be protective in these areas? Well, there are three very important clinical trials that have been published recently related to cancer, cardiovascular disease, and diabetes mellitus. The first study was from Joanne Manson, published a few years ago in the New England Journal of Medicine. This was a very large study of over 25,000 individuals. They obtained mean 25-hydroxy vitamin D levels, and note that the average level was 30.8 nanograms per ml. This is a normal level. Only 12% of individuals had levels under 20 nanograms per ml. Vitamin D was given, and after 1 year, the levels improved on average to 41 nanograms per ml. This was a placebo-controlled trial. The placebo group didn't get vitamin D, and there was no change in those levels among the placebo group. Looking at a number of cardiovascular endpoints shown in this slide, and looking over on the right here, you can see that the hazard ratio did not show any significant effect looking at myocardial infarction, stroke, or death from any cardiovascular cause. But if you looked at cancer, and I've highlighted in red, there was an association, with the development development of any invasive cancer among those whose BMI was less than 25. And if you exclude death from the first 2 years in this study, there was a significant reduction in death from cancer in that group that received vitamin D supplementation. Another prospective study, a bit smaller, but still large, about 5,000 individuals from New Zealand, were given 100,000 units of vitamin D monthly, followed for 3 years, with the endpoint being cardiovascular disease and death. Again, note that the baseline 25 hydroxy vitamin D level was 24 nanograms per ml, with only 1/3 of the population showing levels under 20 nanograms per ml. With the vitamin D supplementation, virtually all patients taking vitamin D had levels greater than 20 nanograms per ml. The placebo group did not show any change. This study looks at the effects on whether that monthly dosage of vitamin D had any effect on cardiovascular disease. And as you can see, there was really no difference between the placebo and the vitamin D group. Moving to the study of diabetes mellitus, this was a study that looked at the potential effect of vitamin D to prevent the onset of diabetes among a group of patients who had prediabetes. Namely, they had either a fasting blood glucose of 100 to 125 milligrams per deciliter, or a 2-hour postprandial glucose of 140 to 199, or they had a hemoglobin A1C of between 5.7 and 6.4%. Any two of these three criteria qualify these individuals as having prediabetes. The study had 2,400 individuals, and they were randomized to vitamin D or placebo. And the outcome was the onset of new diabetes mellitus after 2.5 years. Again, note that the average 25 hydroxy vitamin D level was 28.2 nanograms per ml, and only 20% of the population had levels under 20 nanograms per ml. The group that received vitamin D after 1 to 2 years had an average vitamin D level that was clearly normal, 53.3 nanograms per ml. The placebo group did not change. And looking at this Kaplan-Meier curve, you can see that vitamin D had no effect on the onset of type 2 diabetes mellitus in this high-risk population. Now, there were subgroups studied, and one subgroup that was of particular note in this vitamin D study in diabetes mellitus was related to those individuals whose baseline 25 hydroxy vitamin D was less than 12 nanograms per ml. And in this group, the use of vitamin D did prevent the development of diabetes mellitus with a hazard ratio of 0.38. So again, the notion is that if you look at individuals who are truly vitamin D deficient, there might be an effect. I think these three studies actually have proved another point, and that is that vitamin D is a threshold nutrient. With increasing amounts of vitamin D in people who are frankly deficient, there will be a benefit. But if you supplement vitamin D in individuals who are not vitamin D deficient, a further increase in vitamin D is not likely to give you further beneficial effects. And this principle applies to whatever level you consider to be a threshold normality, whether it be 20 or 30 nanograms per ml. Any levels above that would not be expected to be beneficial. And these three studies I just reviewed for you, patients were certainly above 20 nanograms per ml, and some were reaching 30 nanograms per ml at baseline. So giving more vitamin D to a vitamin D replete population is not necessarily going to have an effect on the outcome variable that was defined in these studies. There are settings in which vitamin D insufficiency or deficiency should be considered. I mentioned falls, bone density when it's low. We always want to know what the vitamin D level is. The elderly, we worry about. Home-based patients with little sun exposure, women who are pregnant or lactating. We know that obesity is a risk factor for vitamin D deficiency, as is bariatric surgery. In addition, medications such as glucocorticoids, anti-seizure meds, antiretrovirals, and antifungals can all affect vitamin D metabolism. But today we want to talk primarily about COVID-19. And certainly COVID-19 has dominated our thinking because of the pandemic that we are all living through. This is a pandemic that is clearly the worst the world has seen in a whole century. And I would like to give you a sense of the scope of this pandemic as of the time this lecture was recorded, namely today. There were 129 million cases in the world of COVID-19, representing 1.6% of the world's population and almost 3 million deaths. In the United States, we have seen 30 million cases, with representing 9.2% of the United States population. There are over 500,000 deaths. You have heard about Brazil, your neighboring country, where there is a terrible situation. At the moment, there are 12.7 million cases, representing 6% of the Brazilian population, and 320,000 deaths. India is an interesting exception. Of course, a country of 1.3 billion people, there have been only 12.2 million cases. That's less than 1% of the population of India, and correspondingly, fewer deaths. In Italy, 6% of the population, and in Chile, not quite a million, but almost a million cases of COVID-19, representing about 5% of the Chilean population, with about 23,000 deaths to date. So it doesn't matter where you look, this is a terrible pandemic, and all countries are at risk. Now, we have focused upon COVID-19 as a pulmonary disease, and certainly it can kill by the pathophysiology of the virus as it relates to the lung. But we now know that COVID-19 is a multi-system disease. It affects our immune system. It can affect our coagulation system, cardiac effects, metabolic effects, effects on the gastrointestinal tract, the skin. There are neurological concomitants as well as ophthalmological ones. So really a multi-system disease. And as I implicated, vitamin D is also not only a single organ disorder. And I've shown this slide before. Now I'm going to focus on vitamin D and its actions on the immune system, the cardiovascular system, and energy homeostasis. And if you pair these up, it's a very interesting parallel. The multi-system effects of COVID-19 on the left, and similarly, the systems in which vitamin D has been implicated, and they match up quite impressively. Looking at vitamin D on infections in general, take tuberculosis. In the old days, tuberculosis was treated by sun and air and cod liver oil. And cod liver oil was used well before it was known to contain a lot of vitamin D. There are many thoughts about vitamin D. as a therapy for tuberculosis. They're not all consistent, but recommendations include vitamin D along, of course, with adjuvant as an adjuvant therapy, along with more specific therapy with antibiotics for the treatment of tuberculosis. But it isn't just tuberculosis. There have been a number of studies that have implicated vitamin D in other respiratory infections. This top bulleted item referred to a study that looked at concentrations of 25-hydroxy vitamin D greater than 38 nanograms per ml were associated with a twofold lower risk of acute viral respiratory infections. Another study looked at levels under 20 or greater, or under 30 nanograms per ml, and again, general risk of pulmonary infections were greater at either of those thresholds. And Adrian Martineau has just looked at this much more globally and showed that there was a general reduction of 12% in those who were vitamin D sufficient, and the effect of vitamin D was greater among those who were more deficient. Now, this meta-analysis by Martineau showed that the odds ratio of pulmonary infections was reduced in populations that were sufficient in vitamin D. Moving to the immune system, this is a complicated slide from Martin Hewison, but it illustrates in some detail that we won't go into that vitamin D is very important for both innate immunity and for adaptive immunity. And this is kind of like a double-edged sword because as vitamin D levels go up, we are protected, we think, from various bacterial and viral infections. And yet, when vitamin D levels are low, we're at risk for an immune system that may not be controlled. So we've got two issues here that unfortunately conspire when we are vitamin D deficient. We are less likely to be protected against infection. We are more likely to be at risk for the inflammatory response to infection. Again, I showed this line. Now I'd like to highlight three areas in which vitamin D has been implicated, and those systems that clearly have been implicated in COVID-19. The coagulation system, the cardiac system, and the metabolic system. We know with regard to the coagulation system that the vitamin D receptor is found in blood vessels, that experimental vitamin D receptor knockout mice demonstrate enhanced platelet aggregation, a downregulation of antithrombin and thrombomodulin gene expression, and an upregulation of tissue factor expression. These are all not good when it comes to preventing coagulation. We also know that active vitamin D downregulates pro-inflammatory signaling and in general reduces a prothrombotic milieu. We also have information about vitamin D in the heart. We know that the activating enzyme to produce 1,25-dihydroxy vitamin D is found in the cells of the cardiovascular system. As well, we know that the vitamin D receptor is found in the heart and blood vessels. And again, these knockout vitamin D receptor studies in mice have shown cardiac hypertrophy, as well as overexpression of the renin-angiotensin aldosterone system. Finally, low concentrations of 25-hydroxy vitamin D have been associated with increased risk of overall cardiovascular events and mortality. And then moving to vitamin D deficiency and diabetes, we have noted that now with regard to COVID, diabetes mellitus is one of the major risk factors for COVID-19. I mentioned earlier that vitamin D deficiency is a risk factor for the development of type 2 diabetes mellitus in those whose levels are under 12 nanograms per ml. And it thus appears possible that the appearance or worsening of diabetes mellitus and COVID-19 could be related to vitamin D deficiency. So what is the evidence to argue that vitamin D has a role in COVID as a risk factor and also for its severity? Well, there are three bits of evidence that I will review that make a case, not a compelling case, but at least an intriguing case. Let's first discuss epidemiology. Levels under 30 nanograms per ml are typically seen in ICU settings. In this study, 75 to 85% of individuals hospitalized in an intensive care unit. In Europe, historical means of individual countries with lower levels of 25-hydroxyvitamin D are typically associated with greater incidence of severity and illness. And we know in the United States that studies have shown that low levels are strongly correlated with mortality and other aspects of poor outcome in COVID. In Italy and Spain, countries that have the highest prevalence of low vitamin D, there is the higher prevalence of COVID-19. We mentioned the latitude dependence of vitamin D. It's also true that higher fatality from COVID-19 in the United States are associated with higher latitudes in the US, and also that higher prevalence of severe forms of vitamin D, of COVID-19 are seen in those who are vitamin D deficient. Now, there are observational studies relating 25-hydroxyvitamin D to COVID-19. This is a recent systematic review of 9 studies involving over 1 million participants, concluding that low levels of vitamin D were correlated with COVID-19 infection, as well as its severity and mortality. Another systematic review of 10 studies involving 360,000 participants concluded that COVID-19 positive individuals had lower vitamin D levels than COVID-19 negative individuals. Observational trials also include this study, where low levels of vitamin D, and I've shown you by the arrow here, levels under 20 nanograms per ml, were associated with a much greater odds ratio of death in COVID-19. Another observational trial looked at 129 consecutive COVID-19 patients. Now, this one was an interesting trial because it ran against all the other studies. This study actually showed that 25-hydroxyvitamin D was not associated with a negative clinical outcome. Now, this study seems to be at variance with the studies that I reviewed, as well as this study that was recently shown at ASBMR by Luigi Gennari in Italy. And this study looked at 102 hospitalized patients and it looked at 25-hydroxyvitamin D levels in terms of those who were or were not hospitalized, as well as those who were or were not in an intensive care unit. Among the hospitalized patients, the average level was 18 nanograms per ml, and those in the ICU, the levels were even lower, namely at 14 nanograms per ml versus those who were hospitalized but not in the ICU, where the average level was 22 nanograms per ml. These hospitalized patients had lower levels compared to COVID-19 patients who were not hospitalized, in which the level was normal at 30 nanograms per ml, not different from the control of this study. And again, further, Gennari has shown that the severity of COVID-19 was related to the levels. In red, you see COVID-19 subjects on the top panel, the levels, those not in the ICU, you can see the red bar is lower in those who were in the ICU, and in those who passed away, the levels were even lower. And in this next panel below, Looking again in red were those whose levels of 25-hydroxy vitamin D were between 10 and 19 nanograms per ml. You can see they represent a disproportionate number of subjects in terms of those who were in an ICU or who passed away. Very recently, and this paper is currently in press, a systematic review by Ghada El-Haj Foulahan from Lebanon, looking at the impact of vitamin D status and supplementation on COVID-19 related mortality and health outcomes. This was a very well done systematic review canvassing a very, very large literature. What she and her colleagues did was to narrow this to 31 peer-reviewed observational trials, and the results of this are shown here. If the 25-hydroxy level was less than 30 nanograms per ml, there was an increased risk of mortality. In terms of ICU admissions, invasive ventilation, disease severity, and SARS-CoV-2 positivity, all were greater, or there was a trend for greater risk among those individuals whose 25-hydroxy vitamin D levels were less than 30 or less than 20. There were other levels here, outcomes here that did not show significant associations. And here are some of the meta-analyses from this study making the point that vitamin D deficiency was associated with mortality, SARS-CoV-2 positivity, as well as infected or versus non-infected subjects. So from epidemiology and observational trials, there appears to be a relationship between vitamin D deficiency and increased risk of COVID-19. It also appears that vitamin D deficiency is associated with an increased severity of illness. Now, in terms of intervention, there are a few studies. This is an observational study just published from the UK, looking at a large number of subjects who were given various cholecalciferol regimens, with the primary outcome being COVID-19 mortality. And it turned out that those who received the cholecalciferol, regardless of baseline 25-hydroxy vitamin D, appeared to have less mortality from COVID-19. A study that has been widely quoted is from Spain, looking at 76 consecutive patients hospitalized. These patients received other therapies as well as 25-hydroxy vitamin D in a ratio of 2:1. And looking at the font in blue, 50 treated patients who received the calcividiol, only 2% were admitted to the ICU with no deaths, versus 50% who were not treated with 25-hydroxy vitamin D were in the ICU, and there were 2 deaths. Now, there are questions about this study. It was not double-blinded, it was not placebo-controlled, and the numbers were small. But nevertheless, this is what we have at the moment. And I would say, reviewing the current evidence for vitamin D supplementation and outcome in COVID-19, even though the data are incomplete and inconclusive, I think that vitamin D supplementation might be associated with reduced risk of COVID-19 infections and death. So we come to very intriguing parallels here between the multi-system effects of COVID-19 and the multi-system effects of vitamin D, and one is intrigued about a possible link. There are caveats. Most of the reports are preliminary, retrospective, observational, or associative, and there are a paucity of prospective clinical trials. But nevertheless, I think we can conclude that vitamin D is an important nutrient and is required for optimal skeletal health. Most of Chile's population, and indeed the world's population, needs supplemental vitamin D. Vitamin D may also have key roles in non-skeletal systems. Vitamin D appears to be associated with COVID-19. Vitamin D may reduce risk, morbidity, and mortality in COVID-19, but the data are not conclusive. There are other risk factors, obviously, for COVID-19, such as age, obesity, diabetes mellitus, and sex. So I think what we need are well-designed interventional clinical trials to investigate the potential benefits of COVID-19 as it relates, the benefits of vitamin D as it relates to COVID-19 on risk, severity, and outcomes. My thoughts about this for recommending 25-hydroxyvitamin D levels in Chile and other countries during the era of COVID-19. I think since low levels of vitamin D appear to be associated with risk for and severity of COVID-19, it seems reasonable to recommend at this time that all individuals maintain levels that are well within the normal range. And I actually go further to recommend that the goal for all of us be set at 40 nanograms per ml or 100 nanomoles per liter, as long as we are dealing with COVID-19. It has truly been a pleasure to be a participant in this very important Congress. I hope to be available in a live Q&A session with regard to this presentation, as well as the other two that I gave. And I really want to thank the organizers and Hector and Claudia and all of you for giving me the opportunity to be part of this program.